A very good morning to one and all. I'm Dr. Vaidishwari, first year postgraduate. Welcome you all on behalf of Department of Anatomy, MGMCRA, SBV, Puducherry for guest lecture 2 on chronic liver disease in India for first MBBS 2023-2024 batch. Respected dignitaries, HOD, resource person, faculties, postgraduates, and our dear students, MGMCRA and Satya Sai students, a warm welcome to all of you. Now I humbly invite our organizing chairperson, Professor Arunmoli Sir, head of the department, on to the dais.
Will combine. Yeah, very good morning. So this is our guest lecture 2. This is mainly for the MBBS batch 23 students of Mahatma Gandhi as well as the Satya Sai students. Since we have completed the abdomen in that liver, we wanted to have this lecture so that maybe I didn't see the slides, right? Maybe it will be undergraduate level. Sometimes, right, as a consultant, right, he may go into the postgraduate or the consultant level also, right? We told him to stick to this one, or otherwise the Q&A session, you can ask the questions. We hope, right, this will be useful for the undergraduate students. As you are aware, even in your IA2, there was a question on liver, and also the portal hypertension was there. So he is going to talk about the liver diseases, right, which affect the Indian population, right. So with that, I welcome all the faculties here, and then also the students of both the institutes, and also those who are on online also. We welcome, and then over to SMC. Yeah, thank you.
Thank you, sir. Now I invite our organizing secretary, Mr. Echraj sir, to introduce the guest speaker.
Good morning, all. I am very happy and honored to introduce our guest speaker today's session, Dr. Arun sir. He has done postgraduate in DNB in pediatrics and DM in medical gastroenterology. Currently, sir is working as an assistant professor in Department of Digestive Health and Disease in Kilpauk Medical College, Chennai. And also, sir is a consultant gastroenterologist in Apollo Hospital, Chennai. Sir, he has worked previously as a assistant professor in Department of Hematology in MMC, Madras Medical College, Chennai. And he is a member of Indian Society of Gastroenterology and European Society of Gastroenterology and American Society of Gastroenterology and Society of Gastrointestinal Endoscopy of India. And sir has very much interest in the research activities. To say few, he has done the research topics in ulcerative colitis and association of the neutrophil lymphocytes radio with disease severity, and assessment of the liver function test and its correlation with the inflammatory markers and cardiovascular abnormalities in liver cirrhosis. And he has a special interest in the role of plasmapheresis in liver transplant, immunosuppression in liver transplant. And sir has the achievements in endoscopic ultrasound, pancreatic endotherapy, third space endoscopy, 2 months fellowship in the endoscopic ultrasound procedures.
Thank you, sir, for a briefing about our guest speaker. Your introduction has set the online stage for an enlightening program. Now I invite our respected resource person, Dr. N. Arun sir, to start the session.
Thank you very much for your wonderful intro. Respected professors, senior consultants, my dear students. It's really a great pleasure for me to join in this wonderful occasion in the early morning hours in Mahatma Gandhi Medical College. And I would like to extend my gratitude to the entire team of Mahatma Gandhi Medical College, and I would like to extend my warm gratitude to Professor Dr. Arunmoli sir, who gave me opportunity to be here along with you all. And I did my medical graduation in Annamalai University in 1999-2000 batch, and Professor Arunmoli sir was my own anatomy professor, such a great professor. And we have learned all the basics through him. And it's really a pleasure our professor be inviting me to join in this wonderful occasion. And thank you very much, sir, for your kind invite. And see, to talk about chronic liver diseases, that too we can do in any population to cater. For example, if you're going to talk on any postgraduate forums, or if you're going to talk in any DM consultants forum, it'll be very easy to discuss about this chronic liver diseases in India. But to address such scenario for MBBS early graduating students, to discuss about the basics and functions as well as your biochemics pathway and all those things, it's still a very challenging task for most of us. My intention, before we are going to wind up this session, so something we should know about chronic liver diseases in India, what is the current scenario, and as of now, where do we stand in this chronic liver diseases? So basically, as you all know, to start with anatomy, since the lecture is going on anatomical area, so what is this chronic liver disease? In case if your liver function, if it is going to get deteriorated, see, you should know the liver is such a wonderful organ which does enormous number of functions. My area, I'll be talking on mainly basics. I will not go into very high area level of discussion. So it will be taking on with more than 500 to 1,000 functions as of now, which is happening in the liver. And as you all well aware, the normal liver, which is located in your right upper quadrant, will be around 1 to 1.5 grams, kilograms of weight. So it may vary from 1.4 kilograms to 1.8 kilograms of weight for your normal liver to consider. And it does more than 500 functions in your normal human body. In case if any problem, if it is going to happen in your liver based upon various etiological factors, if it is going to happen. So what are the various manifestations you are going to face? What are the various investigations available to diagnose this presentation? And how are you going to localize the findings? And what is the newer modalities of treatment which is available? And how to recognize the complications earlier? And when you're going to refer the patient for liver transplant. These are all the areas we need to address when you're going to talk on liver diseases, which is happening right now in India. It's very common scenario to each and every individual in a day-to-day practice. Number 3. So what do you mean by chronic liver disease? If your liver function, if it is going to get deteriorated for more than 6 months continuously, for example, your synthetic function, your protein metabolism, your coagulation cascades, and all those areas, if it is your bile excretion and your protein metabolism pathway, all those things, if it is going to get deteriorate over a period of 6 months, so what is going to happen? You're going to land up with various complication and presentation. This scenario, the entire entity is called as chronic liver disease. So briefly about the outline, as you all know, the liver weighs about around 1.5 kilograms, and in the neonate, it's approximately 5% of your body weight, and the hepatocytes represents approximately 80% of your cytoplasmic mass, which is happening within the liver. And as you all know, the complete anatomy, we should remember my intention, there are 2 lobes, the predominant left as well as right, and each segmental anatomy based upon your cunoids, you need to identify that. Apart from, you should remember about very important portal trail. You're based upon your portal vein along with your hepatic artery as well as your bile duct, which is going to get involved. And the various lobules, almost around 500 to 1,000 lobules being located in every aspect of your liver. That's a basic thing we need to remember about your outline of your anatomy. It's not my area to take on to this discussion, but what is happening once the patient is going to land up with evidence of chronic liver disease? What are the various aspects we should remember? That's the main intention for me to take on with this discussion. And your portal vein, hepatic artery with your bile drainage ductules all run together to infiltrate each and every segment of your liver. That's the most important thing. And Regarding the zones, we need to consider what is the zone 1, zone 2, as well as zone 3 in your liver anatomy if you're going to relook at. So zone 1 is nothing but your periportal, and zone 2, it will be a transition, and zone 3. So zone 3 will be more prone for hypoxemic damage. So what is going to happen? All the drug metabolism which is going to happen in zone 3, in case if there is any insult, for example, any infective insult, for example, any drug-induced insult, so many insults may happen to your liver. The hypoxic insult, if it goes going to get happen, what is going to get? The biotransformation, the liver metabolism, various drugs is going to get affected. So most sensitive damage due to ischemic lesion as well as your congestion, apart from your hypoxic focus. And the main blood flow, as you all well remember that there are two distinct supply, one from oxygenation source from your hepatic artery, a nutrient-rich flow from your portal vein. That is why the portal hypertension is very important, because as you all know, the portal vein get formed because of your SME and splenic, which is going to join beyond your neck of pancreas. It's going to take on with your portal circulation, which is the main nutrient focus for your liver. Once if any portal hypertension, which means your hepatic venous pressure gradient, if it is going to be more than 5, and if it is clinically significant portal hypertension, in case if it's going to get happen more than 10, so what is going to happen? That's the area where your portal hypertension is going to get kicked on. There are various etiological factors for your portal hypertension. One, because of your pre-sinusoidal, your sinusoidal, as well as your post-sinusoidal. I'll be talking on those areas briefly, but you should remember that the liver consists of two main lobes, as I discussed, of around 8 segments with 1,000 lobules and small. These lobules are connected to small ducts with a larger duct to form the common hepatic duct. The common hepatic duct will join with your cystic duct, which comes from the gallbladder, will make the bile duct to get formed. And the bile duct will, along with the pancreatic duct, if it is going to get joined, so that the area where it's going to open into your ampuloquator. These are all the basic things you should really remember as your anatomies. And right now, about the basic function of your liver, mainly by your metabolic function. That very common scenario, your carbohydrate, your protein, as well as fat metabolism will be one of the most common things we should not forget. And the reservoir, so it can accommodate each and every liter of plasma, and apart from that, it will be acting on your blood cleansing agent. So your phagocytosis, your debris changes, your antigen processing via your Kupffer cell, all those things will be taken on by your liver function, and mainly by your bile synthesis and excretion. As you all know, the bile synthesis is an entirely different area, starting from your uptake, conjugation, excretion, and formation. So why we should talk about this bile in a normal human being, in case if there is any evidence of obstruction which is happening, that might be having evidence of obstructive jaundice for the patient to develop. So the basic liver functions are your bile production, your protein metabolism, and your cholesterol metabolism, and your conversion of excess glucose into glycogen for storage, and regulation of your amino acids, blood levels of amino acids, which forms the main building block of proteins, and hemoglobin processing, as well as for its use in iron content, and your poisonous. See what is going to happen in hepatic encephalopathy. Once if the patient is going to have evidence of liver disease, the patient will go into state of confusion. That scenario, what is called as hepatic encephalopathy, in which your brain starts suffering. At that point of time, your ammonia and ammonium levels, if it is going to go high, so that's the area you should not forget. And this, if your liver function is going on very well, then the poisonous ammonia to urea, as you all remember, the urea cycle, which is going to happen predominantly in your liver, so we'll be taking on with that. And clearing the blood of drugs, all blood clotting, very important in your physiology, starting from your factor 1 to 13, the regulation of blood clotting process, which means taking on with your liver function, and your immune system is going to get well augmented, and your resistance of infection is going to well develop, because once the liver function is going to get well established. These are all the basic outline. So what is going to get happen? The normal liver size, which is around 1.5 kg, it's going to get shrunken off because of your various etiological reasons, That's the scenario what is going to call as liver cirrhosis. Once liver cirrhosis establishes, so how do you going to tackle that? So in case if I'm going beyond the time, you please stop me at any point. So the most important thing is you should remember the natural history. This is the main area for me to take on the discussion right now about your chronic liver disease. As your basic MBBS students, you should not forget, in India, the common cause for liver problem, unless and otherwise, if the patient is alcoholic. So we need to think in terms of alcohol. Alcohol is very common scenario because the root cause for alcohol starting from your undergraduation, post-graduation, and I have seen many, even many patients, many doctors, starting from your undergraduation, be consuming alcohol. So based upon, you need to be very cautious. Alcohol is one of the potential factor for you to predispose to liver disease. So cut down the alcohol, even though 30 grams of alcohol consumption in a day might be having some cardiovascular protection. But my personal suggestion, no, because there might be chances of your abuse to go on with your alcohol. So we need to be very, very cautious when you're going to use it. So what is going to happen? If, for example, I'm telling you, once if you're going to take alcohol for a duration of time, as you all well remember, there are so many other combinations of your alcohol. For example, your beer, your brandy, whiskey, rum, toddy, and so many other things are there. For example, if you're going to consume 30 ml of your hard, for example, brandy or something else, which is almost equivalent to your 100 ml of wine as well as your 250 ml of beer. So 30 ml of brandy is almost equivalent to 250 ml of beer. So if you're going to take alcohol for a longer duration, if you're not going to take food, if you are going to lose your metabolism, if you're going to lose your weight and prolonged duration, prolonged starvation, so what is going to happen? The liver continuously will be suffering. Once the liver suffering gets more worsening, what is going to happen? At that point, the patient is going to land up with evidence of chronic liver disease. Chronic liver disease is a condition. At that point, the patient, there is high chances to go for the end-stage liver disease condition, what's called as cirrhosis. Once a patient, what is cirrhosis? Scarring of your liver tissue. Your fibrosis and scarring, it's going to get taken on, and the liver is going to get shrunken out. That is nothing but your cirrhosis to get set in. So once a patient is going for cirrhosis, there are two entities are there. What is called as compensated cirrhosis, and another one is called as decompensated cirrhosis. Simply, you should remember that what is decompensated cirrhosis is, if the patient, obviously in exams, if you are going to get a decompensated liver disease, it will be a usual scenario for any MBBS students in final exams. So, which means most of the time the patient will be having big tummy. The patient will be having gross ascites. What do you mean by ascites? As you all remember that it's a lot of fluid is going to get accumulate in your peritoneal cavity. So it's also called as ascos, which is nothing but your bag of soft warm appearance which is going to get happen. So what you would like to point out this, once the patient is going to land up with ascites, which means the patient's survival is going to go down. And at that point of time, the rate of survival, because in case if it's going to get happen because of your liver disease, the rate of survival will be less than 1 year. So you need to be very cautious in tracking the presentation early when you're going to suspect chronic liver disease. So chronic liver disease, which is going to happen because all the synthetic functions are going to go down. There might be two entities called compensated and decompensated. Compensated means when you're going to do the ultrasound or any imaging, you will be identifying the picture. But clinically, the patient will be absolutely fine. He will not have jaundice. He will not have any rashes in the body. He will not have evidence of coagulopathy. What do you mean by coagulopathy? There are signs of coagulopathy. You may develop petechiae. You may develop purpuric spots. You may develop ecchymosis. There are so many signs in liver disease. Liver disease is such a classical area in which the stigmata you can able to identify starting from your head to foot comfortably. I'll be showing it to each and everything for you to identify that. And finally, once a patient after decompensation, the patient is going to die. So compensation to decomposition mainly because of your complications. What are the complications? For example, if the liver size is already going down and the doctor is advising the patient not to drink alcohol, stop your alcohol. But the patient, most of the time in Indian scenario, will not follow your advice. No one will follow doctor's advice. So what is going to happen? The patient starts consuming more. So what is going to happen? The compensation is going to take on with your decompensation. So the patient may develop blood vomiting. So what is called as your your upper GI bleed, your emetemesis can happen. And once the patient goes with evidence of your huge amount of blood vomit, that scenario may have worsening of your melena. What do you mean by melena? If you're going to pass a tarry black motion, tarry black stools. So that's nothing but melena. So what is the normal composition? So if around 50 ml to 60 ml of blood, if it is going to come out from your body, at that point, it's going to get eliminated from your stools. There's an area for you to develop your melena and other things. And your ascites, your encephalopathy. Ascites, as I discussed, your fluid accumulation in your tummy, and your encephalopathy is nothing but because of all the liver damage, slowly the ammonia, which is going to enter into your mind, will disturb you completely. So that is the area which land up in the evidence of hepatic encephalopathy. And the huge list of grading systems are there for hepatic encephalopathy. It's beyond the area of discussion. So why I would like to point out this? What are the various factors? If you're going to have, for example, hepatitis, common scenario you should not forget, your hepatitis. There are so many viral hepatitis. For example, your hepatitis A, B, C, D, and E. All these things will have liver disease effect. You may land with liver disease. For example, once you're going to develop your hepatitis A, usually you will recover rapidly because it's a waterborne. And hepatitis E too. But hepatitis B and C, it will go into chronicity. Most of the time, the patient will not know. It is going to spread through your blood transfusion, usage of blood and blood products, your sexual transmission, so many other modalities, needle sharing. And one, you may not have any signs and symptoms outside. When you're doing a master health checkup or when you're doing a routine surveillance for something else, you may identify with hepatitis B as well as C. These are all the dreadful, dangerous viruses you need to recognize, like your human immunodeficiency virus, HIV. These all three will go together. So you need to recognize this immediately because these two entirety, B and C virus, will make you to turn into liver disease. And finally, the patient may have evidence of liver cancer called hepatocellular carcinoma. And finally, the patient may go for death. So you need to recognize. Another common important etiological factor is your NASH. So non-alcoholic steatohepatitis. This we should not forget, very commonly nowadays in Indian population being recorded. What is this non-alcoholic? If you're not going to take alcohol, so okay, fine, doesn't mean you're not going to develop any liver disease, because even if you're non-alcoholic, there is a possibility in case if you're going to be obese, you should remember your body mass index. If it is going to be morbid obesity, if it is going to be more than 30 plus your BMI, and in case if the patient is having coexisting comorbidities like your type 2 diabetes, your long-standing hypothyroid, your patient is having morbid obesity, your metabolic syndrome, your dyslipidemia, cholesterol not maintaining well in your body. When you're going to do your routine profile, you can identify your fatty liver in your ultrasound. You are seeing many patients' ultrasound reports nowadays with evidence of fatty liver. Is it simple or complicated? No, it's more complicated. You need to be very cautious. Once a patient is going to develop fatty liver, that's a fast alarming bell, the death knell already inside. So we need to be very, very cautious at that point of time. So what is going to happen? The patient may go worsening of events like your jaundice and other things to take on nothing but non-alcoholic steatohepatitis. And these are all the areas, various precipitating factors, your alcohol, infection, your NASH and other things, and your what's going to happen, your inflammatory changes, which is going to get checked on in your liver, which will predispose to early fibrotic change, and the architecture, which is going to get disrupted because of that. The function is going to get interrupted because of that, and your aberrant your hepatocytes is going to get regenerated and you are going to land up with evidence of cirrhosis. Once you're going to develop your liver cirrhosis, which means the complete scarring being taken on, though 1 to 5% of the population may go for your liver cancer. So that is very, very dreadful complication. You need to be very careful. And once a patient is going for liver cirrhosis, the most common treatment modality, there is no treatment as of now. Only we can able to prolong the life once a patient is going for liver cirrhosis. We cannot able to revert the cirrhosis completely unless very rare scenario, very rare etiology that might be misstood as cirrhosis, that might improve on the early fibrotic changes. But usually liver cirrhosis, once a patient gets land up with evidence, the patient may continuously tend to progress. So that kind of patient may need to go for liver transplantation. So liver cirrhosis is nothing but your damage to the liver tissue, which is going to be predisposing to fibrotic changes as well as your nodular regeneration. So the various definitions, so the basic thing, the architecture is going to get lost, as well as your fibrotic changes, your regeneration of your parenchymal nodules, which is going to get taken on. So that's the area for your cirrhosis. And this is the basic thing. Repeated destruction of your hepatic cells causes the formation of your scar tissues. As you all remember that the 3 main characteristics for your liver cirrhosis to take on by fibrotic changes, your nodular regeneration, which means micronodular, mean there are 2 categories for micronodular cirrhosis and another one is macronodular cirrhosis. The micronodularity, if the liver the nodular size, if it is going to be diameter less than 3 mm, and macronodular, if it is going to be more than 3 mm, and these are all there are various etiological causes for your micronodular as well as macronodular cirrhosis. You'll be doing that, and the disruption of the architecture of the entire liver is going to get happen. So what is going to get happen? So once the vascular architecture is going to get reorganized in your cirrhosis, so that is where your splanchnic vasodilatation. So what is going to happen once the portal pressure, the liver pressure, if it is going to get high, what is going to happen? The splanchnic vessels are going to get vasodilated. That is why once the portal hypertension develops, you are going to develop a complication, what is called as variceal bleed. So varices will be forming. As you all well remember that there are so many collateral circulation. That's why the portocaval anastomosis is very, very important. I'll be showing that in a key diagram. You should remember that. And you should remember the basic Greek word. It's also called as a cirrhosis, derived from your orange or tawny appearance. And this is the condition which is going to get predisposed. What is the WHO definition? The liver necrosis and fibrosis and conversion of normal liver architecture into structurally abnormal nodules that lack your normal lobular organization. It's a basic definition. What is the statistics, epidemiology? What's happening right now in India? Around 10 lakh patients. Say every day you'll be having multiple complications. Nowadays, non-alcoholic fatty liver disease, initially, which has been happened in the Western country, nowadays being reported more in Indian scenario because diabetic capital is India. So you need to be very cautious of diet control, lifestyle modification, physical activity, exercising, regular monitoring, regular assessment, avoidance of unwanted medications, avoidance of all those stuffs will help you to prevent liver disease. You should remember all the basic factors right from your basic knowledge of your MBBS, and you need to get progress along with that. So liver disease occupies the 10th most common cause of death in India and may affect every 1 in 5 Indians. And liver cirrhosis is the 14th leading cause of deaths in the world and could be the 12th leading cause of death in by 2020 to 25. So main types of cirrhosis are 4 major classification. Your alcoholic cirrhosis is also called as Lennox, as well as your post-necrotic, your biliary and cardiac. So briefly, I would like to tell you about this, in which alcoholic cirrhosis is very common entity. How will you stage your alcoholic liver disease? The basic thing I will tell you, for example, if a patient starts taking alcohol, what is going to happen? 90 to 100% of the population will land up with evidence of fatty liver within a span of 6 months to 1 year after taking alcohol for a long duration. Once a patient is going to have fatty liver, either the patient has to improve after stopping alcohol, or next stage the patient may go for a fibrotic changes. Fibrosis, a nodularity, and finally cirrhosis. Once a patient is going for cirrhosis, most of the time the patient may go for liver cancer, or the patient may persist with cirrhosis, or the patient may die. In between, there is a stage what is called as alcoholic hepatitis. That stage in which the liver function is terribly affected and the patient may need a ICU care. So you need to be very cautious in recognizing the presentation. Basic MBBS, what we are supposed to remember, alcoholic liver disease is one separate entity to be tackled. You need to be very, very conscious. So counseling is always stop and quit alcohol is the first line of treatment for any patient who is going to land up with evidence of alcoholic liver disease. And the next one is post-necrotic cirrhosis. For example, if you're going to land up with evidence of viral infection or any toxic, for example, if the patient is going to consume a poison, the common poisoning which will predispose to paraquat poisoning, your carbon tetrachloride poisoning, and paraquat and all, if you're going to, for example, if you're coming to Madras Medical College, Chennai, there's a separate ward which is being available, ICU care. For most of the time, the paraquat, what is going to happen, or rat killer paste. So what these things will be predisposing to rapid major liver toxicity. Within a span of time, the patient will succumb quickly. So you need to be very, very cautious. There are all the areas may predispose to post-necrotic changes in which the entire lobule is going to get collapsed in your liver. And biliary cirrhosis. What is this biliary cirrhosis? See, you should remember the bile pathway. In case if the bile pathway, if it is going to get blocked anywhere in the liver, whether it's post-sinusoidal or any other cause, so what is going to get happen, as you all remember that the bile pathway starts from your common hepatic, right and left hepatic that joins to form the common hepatic, which joins with the cystic duct, which comes from the gallbladder, forms a common bile duct, and from common bile duct, it's going to join with your PD, pancreatic duct, to join into the duodenum. In case if there is any obstruction in the level, so what is going to get happen, there might be having evidence of obstructive jaundice. There are so many etiological, thousands of causes are there, but that's not the intention. We should remember all jaundice is not simple viral hepatitis. All big tummy, ascitic tummy is not because of liver. And all liver disease is not because of alcohol. These three entities we should remember before going to wind up the session. Number 10, autoimmune disease, your slow progressive destruction of small bile ducts of the liver and building up of your bile as well as stock. These are all the various etiological factors to be considered for your biliary cirrhosis. What is this cardiac cirrhosis? As you all know, your right heart does the most of the pumping function. So once it's going to get happen, once, for example, your heart failure, if it is going to get take on, and if there is severe tricuspid regurgitation, in case if your valvular function, if it is not going to get happen well, that might be evidence of congestive hepatopathy. So that is also predisposed to liver problems. So cardiac cirrhosis. So it's not directly affecting the liver. Secondary to failing of heart, this cardiac lesion is going to predispose to your liver cirrhosis. So the hepatic derangements in the setting of right-sided heart failure is going to get happen. That's will predispose to cardiac cirrhosis. So how are you going to diagnose that? Proper echo, proper assessment, look for liver factors, everything is fine. The liver might be normal, but the patient is going for cirrhosis. That's the reason for your cardiac cirrhosis to get happen. And etiology, the common scenario in India, alcoholic liver disease. Now viral hepatitis is being well taken out. Around 30 to 40% of the cases being reported. And apart from biliary disease, as well as your hemochromatosis, in which iron overload. If the patient is going to take too much of iron, if the iron transferring saturation, those things is out of the area, I mean, more of theoretical. I don't want to talk in that area completely. Remember hemochromatosis because of your iron overload condition. Simple. Etiological factors, if you remember these basic things, the liver cirrhosis is mainly because of your infective factors, Your autoimmune, in case if your liver functions, it's going to get formed against. There are so many reasons for your autoimmune liver disease. If, type 1 and type 2, those two entities are there. Metabolic liver disease, we should not forget. And next to that, your outflow obstruction. See, if you're going to have a liver problem, sometimes when you're going to examine the patient, you can see so many collateral channels will be developed in the tummy. So the prominent veins will be there in the anterior abdominal wall or in the back, lower back. So we need to identify whether the flow is towards your umbilicus or away from the umbilicus. You need to recognize the complication of caput medusae. So what is it? Snake-like appearance, snake-like appearance. So what is it called? Because of your hepatic vein, which is going to get outflow obstruction, which is going to get happen. The scenario is called as Budd-Chiari syndrome or your veno-occlusive disease. You should remember what is the Budd-Chiari syndrome. If there is evidence of thrombotic occlusion in your hepatic veins, that's nothing but your Budd-Chiari syndrome. Drug-induced, very common drug. You should remember that paracetamol. When you're going to take your fever medicine, for example, of prolonged duration, and I have seen multiple newborn babies, I have seen multiple infants, just like that, they will give paracetamol. I have seen many doctors will be prescribing paracetamol for 1 week to 2 week scenario. So what will happen? For example, if the baby is going to take 1 ml of paracetamol drops or 5 ml of paracetamol syrup, each composition will vary. And most of the time, the mother accidentally will give more dose to the baby. And what is going to get happen at that point, the baby may have fulminant hepatitis because of your paracetamol. As you all remember, there are so many antidotes are there. The main antidote will be your N-acetylcysteine. Nowadays, methionine also being tried. Why I would like to say there are drug-induced etiological factors for your liver failure to happen. The liver failure is something which is entirely different. My intention is not to take on that, but you should remember that there are so many classifications, so many etiological factors for your liver complications to get taken on. And biliary malformation starting from your choledochrosis, so many other causes are there. And you should remember the basic things. Cryptogenic. What is this cryptogenic? You cannot identify a cause. That is what is called as cryptogenic. It may not be virus infections. The patient may not take alcohol. The patient may not having any evidence of outflow obstruction. The patient may not evidence of metabolic liver disease. One metabolic liver disease we should remember always is Wilson's disease. Very common thing in your MBBS level because Wilson disease, young adolescent boy, usually male. So what they will happen, they will develop jaundice, rapidly worsening your liver function, and treating like a, for example, a physician may treat him like a viral hepatitis. But unfortunately, the child may go for a metabolic liver disease, what is called as Wilson disease. So you need to recognize the complication. There might be neurological complications. There might be liver complications. You may develop a classical eye complication, eye presentation. So all these things you need to see for see, liver is such a fantastic entity. When you're going to see the clinical picture, easily you can recognize the complication, whether the patient is going for evidence of cirrhosis or whether the patient is going for evidence of failure or whether the patient is going for hepatic encephalopathy and other complications. Based upon that, you need to decide the treatment protocol and accordingly you need to manage. And pathogenesis, as you have discussed, mainly what is going to happen, the inflammation based upon your various triggering factors and your fibrotic changes, your regeneration, as well as your vascular arrangement, if it is going to get lost. So what is going to get happen? The normal cell sinusoid, if it is going to get completely disrupted, the stellate cell activation, your collagen deposition in your space of dizzy, and the construction of your various sinusoids is going to get taken on at that point. So the patient is going to land up with the worsening of your liver cirrhosis and other complications. The basic thing, remember the triggers. And once the trigger sets in, destruction of your hepatocytes, the patient may go for evidence of fibrotic changes and the bile flow may get obstructed or the portal hypertension is going to get taken on. This is what the portal hypertension I would like to represent to you. The portal circulation, which being enormously being delivered to the various areas. So what is the portal system and the cable system? So once the portal pressure, the liver is going to get an insult. What's going to happen? The portal pressure is going to get elevated. Once the portal pressure, if it is going to be augmented, so the various collaterals, your left gastric vein, your posterior gastric vein, short gastric vein, which is available in the cardia of your stomach. So it is going to get anastomosed with your caval systems. For example, your intercostal veins, your diaphragmatic veins, your azygos veins. So that's why you may develop varices here, and you may develop rectal varices, you may develop a bleed, so many other collateral system in which you can able to identify. So that is why the patient may have evidence of a upper GI bleed. How the liver disease will present with a bleed? This is very common scenario they'll be asking many times. So early morning, usually sudden, without any precipitating, without any burst. For example, if you're going to get vomit, you may have a projectile symptoms, but nothing will be there most of the time. Just like that, the patient will be an outburst of vomit. So what is going to happen? Huge amount of blood. It's a coffee colored or something else. The melanomesis. So a halted blood consistency. It may be admixed with your food particles. A huge volume output. So that's the area to classically represent whether the patient is having evidence of hematemesis. And we need to differentiate it from your hemoptysis, which the blood source, which is coming from your predominantly from the lungs. So we need to differentiate classically by the color of the blood, by the contents, what is going to get admixed, and without any precipitating, just like that, early morning, a trigger, just rapidly outpour. It might be mainly because of your hematemesis. And one more thing, all hematemesis, for example, in case if you're going to see any blood vomit for a patient, it's not because only of liver disease. There are so many etiology for a blood vomit too. That's a different area. But you should remember that it's mainly because of variceal bleed. Variceal bleed means your liver affected. The portal pressure is increased. So the varices is going to get formed. That is predisposing to your bleed. That is mainly because of your variceal bleed. And there is one more bleed, what is called as non-variceal bleed, which means, for example, if you are going to have an ulcer in your stomach, it's called a duodenal ulcer or gastric ulcer. If that ulcer ruptures, what is going to happen? You may have a bleed. So that is also called as a UGA bleed, upper GI bleed. But the usual scenario will be a non-variceal bleed. Non-variceal, the liver function will be normal, the portal system will be normal, and along with, you may not have evidence of varices, but the torrential bleed may happen. So all these pointers you need to identify. So as a MBBS students, you should know the proper anatomy and the complications, how the liver problem is going to get taken on, and the basic functions, what's going to do, and how are you going to recognize the complications early. That is what the main thing is, main area to get addressed here in this scenario. See, the liver insult, once it's going to get taken on, the hepatocyte damage, inflammation, and the huge list of clinical presentations will be there that I'll be discussing with you in my upcoming slides. And see, what are the things? So you may have ascites, edema, varix, hemorrhoids, piles formation, all these things. Because why these things are not happen? Because of your rectal varices, which is being the collaterals being linked to that. And apart from that, you may have massive bleed. Once a portal hypertension, what are the characteristic presentation for portal hypertension? You may have splenomegaly. Spleen is going to get enlarged for sure. Apart from that, usually you may have evidence of upper GI bleed. These are all the characteristic presentation for your portal hypertension. And the scenario is different from your hypersplenism. You should remember that. But you should recognize this complication of your portal hypertension. The bleed and delayed wound healing will be there because of your liver function, the synthetic, the immune function is going to get go down. So clinical representation, huge list of findings are there. So what is going to happen? The hormonal process. So what is ascites? To talk on that, I will tell you briefly. So the hormones called diuresis, the renal diuresis, if it is going to get taken on, so anti-diuretic hormone has to be produced in a good way. So that's the main role regulated by the called vasopressin. So what is going to happen once the anti-diuresis decrease ADH? So anti-diuretic hormones levels, if it is going to go down, So you may have evidence of edema. That is why most of the time the patient may have ascites, pedal edema, the legs going to swollen up like anything. And your metabolism of your carbohydrates, your androgen levels is going to go down. So the libido, all those things is going to get affected. The testicular size is going to come down. Gynecomastia, the male factor, breast development may be there. And the patient wants a liver synthesis if it is going to go down. Hypoglycemia, early morning, suppose the patient sugar levels will rapidly fall off. So you need to remember these things. Bleeding tendency, various bleed. You may have bleed from your mouth, you may have bleed from your gums, you may have bleed from your esophagus, you may have bleed from motion because of your rectal varices. There are huge variety of bleeding symptoms will be there. And obstructive jaundice, you may have clay cholesterol because the bilirubin pathway, the bilirubin, this is a separate physiological area of bile excretion. If it is going to get blocked, what is going to happen? You may have a clay colored stools. The motion color will be clay. Obstructive jaundice will be high colored urine. You remember regarding the jaundice, there are three types. One is hemolytic and your intrahepatic and your obstructive pathology. Hemolysis means useless. For example, starting from your congenital causes, your, for example, your hematological abnormality, your G6PD deficiency, your spirocytosis, yes, all those signs may predispose to your hemolytic focus. And drug-induced hemolysis are there, autoimmune hemolysis are there. So many etiological factors to think about your hemolytic source. And next to that, you need to think about your hepatic causes. For example, your infections like acute hepatitis A, acute hepatitis E. E is very common scenario for the females in pregnant age group. So you need to remember these are all certain examples for you to identify that. And for example, if the patient is having obstructive jaundice, for example, if the patient is having stones in the bile duct, that may predispose to jaundice. That is what is called as cholelithiasis. So if the patient is having gallstones also, so which means the stones which is located in the gallbladder, what is going to get happen at some point of time, it is going to relocate into a bile duct. Once a bile duct is going to get involved, the patient may have jaundice. There are so many reasons for jaundice. So I would like to point out, hemolytic jaundice, the urine color will be acholoric, which means predominantly white. So in obstructive jaundice, the urine color will be predominantly your yellowish eye-colored urine will be there. And clay colored stools is because the biliverdin fragment, which is not going to get excreted. So what is going to happen? The pigmentation will not going to get happen. So the clay colored stools will be the predominant pathway will be in case of obstructive jaundice. So these are all the pointers. And once if your liver is going to get failed, which means what is going to happen? Your INR is going to be high, which means your international normalized ratio, if it is going to be more than 1.5, your prothrombin time, which means the liver synthetic function, if it is going to go down, your prothrombin time, if it is going to be elevated more than 15, or your albumin, normal human albumin should be around 3.5. If it is going to go down, what is going to happen? You may have edema. So the synthetic function is going to get affected. So all these things will be predisposing to multiple complications starting from head to foot. The ammonia will be high, will be having brain coma, there's nothing but hepatic encephalopathy, and you may have various abnormalities of neurological complication, respiratory insufficiency, cardiovascular insufficiency, your failure, coagulopathy, and the patient may have UGA bleed, and finally the patient may succumb. So this is how the event of liver disease which is progressing. I will be talking regarding the clinical features briefly because you should remember the clinical features, very important, how to recognize liver disease for MBBS students. For example, I will be talking on a case scenario. A 53-year-old male who is visiting your hospital with evidence of abdominal distension for the past 1 month. And this distension is also involving the lower limb with loss of appetite, malaise, as well as the sleep pattern has been completely disrupted. He couldn't be able to sleep in the nighttime well. And he's also having evidence of melena, which means a tarry black stool which is going to get happen. And you are a practicing consultant. And this kind of patient is going to come to your OP with this kind of picture. And when you're examining him, he is having evidence of jaundice. And for that, that fellow has gone for a local treatment. What is the local treatment? He might be taking leaves, some homeopathy, Ayurvedic preparations, all those things he might be having before visiting you. So at this point of time, are you going to interfere with its clinical presentation? So the common clinical features will be hepatomegaly. Once a patient is going to land up with liver cirrhosis, usually the hepatomegaly will not be there. But in case of alcoholic hepatitis, if the patient started taking alcohol, at that point, if the patient starts drinking more and more alcohol, he may have alcoholic hepatitis. So all jaundice is not because of liver cirrhosis. So you need to be very cautious. So he may have deep jaundice, he may have liver enlarged, which is 3 to 4 centimeters below the subcostal line. So he may have evidence of hepatomegaly. Once a patient is going for cirrhosis, usually the liver size is going to get shrunken out. You couldn't able to identify the liver clinically by your palpatory method. And your ascites, as I discussed, your circulatory changes. What is going to happen? This vasodilatation, which is going to happen everywhere, the peripheral vasodilatation, and for that, you may develop your telangiectasia, erythema, and your endocrine changes, as I discussed, your loss of libido, hair loss, you may have kind of starting from your head to foot everywhere, the systems is going to get affected, your bleeding tendency. And the portal system, portal hypertension, main thing will be your splenomegaly, your upper GI bleed, and you may have the smell of ammonia once you're going to land up with the evidence of hepatic impairment. That's what is called as a feta hepaticus. And other symptoms will be, so I'll be showing you on, see what is going to happen, the portal pressure is going to get elevated. So once the portal pressure is going to get elevated, what's going to happen? The intrahepatic resistance is going to get increased because of the fibrotic changes which is happening in the liver at the pre-sinusoidal level, and that predisposes to more and more complications. So this is the basic picture you should remember for your clinical representation, starting from your head. So what is going to happen? If the patient is going to, for example, if the patient is going to take alcohol for a longer duration, the patient liver cirrhosis is going to get taken on, take on at that point. So the patient may have evidence of hepatic encephalopathy. So how to recognize that? The first simple thing you should remember, we should see whether the patient will survive or not, number one. Number two, whether the patient is having altered sleep pattern. Most of the time, if the patients have a chronic alcohol, they used to sleep comfortably. But once a patient is going to land over the liver disease, the early presentation will be your altered sleep pattern. Most of the time, the nocturnal sleep will not be good. So they will be having the sleep-wake cycle, the narcolepsy, and all those problems may happen. So that's an early recognition for your hepatic encephalopathy. And GA complications, huge list, as I discussed, your UGA bleed, anorexia, dyspepsia, you cannot able to eat, you may have nausea, vomiting, abdominal distension, so many things are there. And reproductive focus, your jaundice. What is a jaundice? Mainly your yellowish discoloration, which is being happening. So how will you recognize the jaundice? Only when the level of bilirubin, if it is going to be more than 3, you can able to identify jaundice in your eyes. So you need to see for that. And other complications which is going to get happen. And usually, if the patient is going to have evidence of jaundice, abdominal distension like ascites, usually the patient will be anemic. Why? Because the blood cells is going to get destroyed. Splenomegaly happens. So the RBC is going to get destroyed. The patient may have anemia, the thrombocytopenia, platelet sequestration is going to get happen. And your leukopenia. So all these 3 cell lineages may go down. That's what is called aplastic anemic like criteria. So may happen because of your alcohol intake for a prolonged duration of time. That will predispose to your bone marrow suppression. And these things and metabolic complications like your potassium levels may go down, your hyperkalemia, hyponatremia. Once your sodium levels, if it is going to go down, that might be worsening your ascites. These are all the huge list of presentation. I think it's beyond your scope. Why I would like to point out this, you should remember the liver function is going to go down. The patient may have any problems. That's very important. The common things is ascites, you may have swelling everywhere. The good saying is, very good saying, there is a beautiful quote to quote in this area is, the patient usually will be completely nourished, he'll be like a rich man below the level of chest. but he will be like a poor laborer above the level of chest, which means the complete nutrient depletion, the fat loss, the muscle mass, everything is going to go down. What is called as sarcopenia, which is going to happen above the level of chest. So the tummy will be very big, but he will be very thin. So the richness down and the poverty above, it's a classical picture for a patient with chronic liver disease. So the symptoms are, these are all the various symptoms. Always remember high jaundice, any bleeding manifestations, swelling in the legs, high colored urine, sleep completely disturbed, altered sensory. You may ask him some question. He will not respond to the question properly. You may give him a task. You ask him to draw something. He will draw something else. You ask him to do some work. He cannot do that work in proper time. All these pointers, there are so many things are available to diagnose this. All these pointers is mainly because of your liver disease. And the same thing, your symptoms, your attention change, mood change. This is for your hepatic encephalopathy. The characteristic picture will be your sleep is going to get disrupted. Your dysgraphia, your handwriting abnormalities will be very common. You cannot write it down properly. You can recognize this complication early and you cannot talk well. There is orientation will go down. The slow staccato. You will stuck. Like that. You cannot able to talk fluently when you're going to communicate. So as the day progresses, he will have this kind of events in his clinical presentation. So which means this is a high time for you to consider liver transplant to this kind of patient. That is very, very important. What is the sign? It's jaundice. As you all remember that you need to look for evidence of jaundice in your conjunctival area. So what is going to get happen? So once high yellowish discoloration is going to get taken out, the icterus which is going to get developed. So there are so many causes for this jaundice. So it could be your simple infectious or any dreadful infectious virus and alcohol induced and hemolytic causes. For example, as I discussed, your G6PD deficiency and other things, and your liver-related causes and post-hepatic causes. For example, your Budd-Chiari and other syndromes can predispose, all these things can predispose to jaundice. So all jaundice, you need to be very careful. And there are some causes for jaundice, which is not because of liver. For example, your carotenemia. Carotenemia is one thing in which the yellow pigmentation, the carotene pigmentation is going to get deposit extras. So what is going to get happen at that point also the patient eyes may be yellowish in color. Doesn't mean it is because of liver disease. You need to be careful on recognizing this presentation. And this is what is called as dilated veins in the tummy. See, you can able to see the umbilical point, and if you're going to measure the distance, so if you're going to draw a line to your pubic symphysis, so what is going to happen? So the xiphisternum to your umbilicus will be predominantly high when compared to your umbilicus to your pubic symphysis. So what is going to happen? There are prominent veins. See, because of the huge tummy which is going to get developed. This is nothing but your ascites and with dilated veins. If the dilated veins become very prominent and you can able to identify obstructions called as caput medusae. Itching and pruritus. What is this itching? Why? Because in case, for example, if the patient is having obstructive jaundice, so what is going to get happen? The pigmentation, the bilirubin pathway is not going to get function well. So at that point, the patient will start and severe itching and pruritus. So that is why most of the time they will be prescribing your molecule called UDCA, nothing but also deoxycholic acid to detox area. So why? This is very classical. The patient used to scratch continuously. So you can recognize the patient is going for liver disease. You can recognize the patient is going for other complication in the background of jaundice. And mostly this kind of thing will happen in the later age of presentation. And for, 50s to 60s, 60s to 70s, so there will be a continuous itching. So you need to see whether is there any blockade anywhere in the bile duct. The patient may have dangerous cancers like your cholangiocarcinoma, which means the bile duct cancer. So all these pointers you should remember briefly, and all this entities may affect your liver also. You should remember that. And this is what is called as your leukonychia, which means pigmentation is not going to be there. The skin is going to take on the white color. The leukonychic changes because of your chronic alcohol intake. And spider nevi, this is what is a arteriole which is going to get formed in this area. This is the vascular lesion. So if the spider nevi, if you can able to identify the skin, so you need to be very cautious. If you're seeing more than 5 to 6 spider nevi, which means the lesion, the liver problem is very active. And suddenly, if you're seeing 5 to 6 spider nevi, and within a span of time, next day, all the spider nevi, if it is going to get disappear, which means what is happening? The liver failure is going to get worsened, which means the liver synthetic function is going to get worsened. At that point, the patient is going for fulminant hepatic failure. So the rapid disappearance of your spider nevi or angiomas makes you to alert you that the patient is having fulminant worsening of event. That's a pointer. So petechiae, purpuric spots, ecchymotic patches, all those things may happen. And this is nothing but your Dupuytren's contraction, which is going to be because of your all the, elastic tissues of your, and if it is going to go down, and apart from that, your clubbing, as you all know, the various grades of clubbing, your obliteration, your parrot beak and drumstick, and your hypertrophic changes. So clubbing is very characteristic presentation for any chronic liver disease, and you may not have clubbing for all the patients. You need to be cautious in recognizing, and this is what is called Dawson sign. It's called palmar erythema because of your metabolic pathways, your androgen estrogen pathways. If it is going to get disrupted, so at that point you may have this palmar erythema. Pedal edema, you may have swelling in the legs, so always you need to see for pedal edema. This is what is called as pitting pedal edema. And there are some entities what is called as non-pitting edema. For example, if you're hypothyroid, most of the time you may develop a non-pitting pedal edema. So you need to be cautious. This is characteristic. So ask the patient to extend the hand. If the patient is chronic alcoholic, you may have this flapping tremor or wing beating tremor. What is it called? It's called asterixis. So this is very characteristic for hepatic encephalopathy. So what is going to happen? Most of the time, the patient will be in liver hepatic encaph stage 2. So you need to recognize this kind of complications quickly when you're going to recognize a patient with chronic liver disease. And next to that, once a patient's splenomegaly, portal hypertension, RBC starts getting distracted, what is going to happen? You may have hemolysis and other things. So at that point, you may develop gallstones and caput medusae. So this is what I told you. This is snake-like pattern of appearance, a cobra pattern of appearance. So what's going to happen? The portal hypertension is going to happen. At that point, the blood is shunted to from the periumbilical veins to the umbilical vein and into the abdominal wall. So you can able to see such prominent veins in case of liver disease. In case of any obstructive lesion, for example, your IVC obstruction, you can able to identify this kind of findings in the back. In case you have hepatic vein obstruction, you can able to identify the findings in the anterior abdominal wall. So all these pointers you need to be cautious in remembering. So caput medusae is one more stigmata. There are a huge list of stigmata starting from air loss to lower down in your foot. You need to see all the presentation. And this is not the common thing. Gynecomastia may report male type breast pattern, and your caput medusae hernia in your umbilicus is usually called as paraumbilical hernia. And your edema or swelling the legs, as I discussed, you may have your lower limb varix and all those complications. And apart from that, you list of your clinical examination. So look for all the clinical picture and look for evidence of stigmata of liver disease. And once you confirm that, what are all the lab tests you are going to do that for the patient?
Dr.
The
Arun,
basic lab.
Dr. Arun,
Yes, sir.
yes, just 1 minute break for you.
Yes, sir.
Okay, so I will make the students, right, to get the feedback in between. Okay, yes, students, you started sleeping. Okay, take home message till now, right? What do you feel? Yeah, we'll start by the table groups. Table 1. Yes, table 1. What did you understand so far? I want the interaction from the students so that even the resource person will be happy that he has done his job perfectly well.
No
Yes.
worry. Answer simply, very simple things.
Yes. What is he talking about? The cirrhosis, right? The most of the thing is cirrhosis. What are the clinical features of the cirrhosis? And what is the common etiology for cirrhosis? What's the etiology for cirrhosis? Yes, students, yes. What's the etiology for the cirrhosis? He has mentioned 60 to 70% of cirrhosis is due to, yes.
Allow him to continue, sir.
Okay. Okay. Yeah. Dr. Arun?
Yes, sir. I
Yeah,
couldn't able
yeah.
to hear his voice.
Yeah. I want a break for you.
Yeah, I'm very happy to enjoy this because it's remembering my past.
Yes. I still remember 1999, right? You are a very calm student now. It's really to see you after 25 years, right? So with
Sure,
your
sir.
brilliant idea, and then it's going to be useful for the students also. Yeah, you can continue, Doctor. Yes. Thank you.
Yes, sir. See, as a students of MBBS, what I would like to point out, see, I don't want to take huge list of discussion, which makes you very sleepy and very boring. And I can able to understand the session almost going beyond 1 hour as of now. So huge list of, you may tend to sleep. So my intention, if you remember few points in this area, I'm very happy. Next to that, the basic lab investigation. So you are going to see the patient clinically. You are identifying some sort of problems. You identify jaundice, blood vomit, and once a patient is having ascites, swelling in the legs, gynecomastia, so many complications. You are going to see the redness in the hands. So many complications you are identified. So what are you going to do next? That's a question. Now you need to answer that. So you need to do the blood workup. The common blood work, if you take a blood sample, you need to see anemia. What is anemia? Very common. If hemoglobin, if it is going to be low. For example, females means 12, men means less than 14. If it is going to go down, usually in liver disease, the hemoglobin range will be in 8 to 10. So that's a characteristic presentation. Apart from that, the liver function. The commonest liver function is your various 3 liver bilirubin levels you're going to see. Your liver enzymes, like your major liver enzymes, like your OT and PT, which means your AST and ALT, which means your aspartate your alanine transaminase. Apart from that, your GGT, which is a high level of indicator for your liver damage because of alcohol. Apart from these are all the signs of hepatocellular lesion, which means that problem which is predominantly happening in the liver. And there are 2 pointers for your obstructive pathology, which is happening in the level of bile duct. What is called as ALP, alkaline phosphatase, and nucleotide. So many other things are there. That's not the intention. You should remember in liver problem, the albumin, which means the predominant synthetic function which is going to happen mainly because your albumin function. So albumin, if it is go down, if it is going to be less than 3.5. So what is going to happen if, for example, most of the time in liver problem with massive tummy, the patient albumin will be only 2 or 2.5. So you need to be cautious. You need to give albumin injection. You are seeing the yellow colored bottle will be giving in most of the ICU setups. So you need to give 100 ml of albumin to the patient. So the albumin level will be predominantly low if the patient is having ascites. Number 2 is your INR will be high, your prothrombin, which means the blood clotting, which is completely gone. So that is why wherever you touch, for example, if you want to put an IV line to the patient, if you want to put a central line to the patient, you will have enormous amount of blood loss. So that is why the coagulopathy, the liver synthetic function completely gone. I know many patients, for example, a young male, few days before I have seen in Apollo, who died because of a ractol paste poisoning. Why? See, this patient has taken a huge amount of rat killer paste, and immediately within 24 to 48 hours, he been reported to us. We didn't even admit the patient is almost gone into state of collapse and coma. So we have declared on spot that the patient died because of rapid worsening of symptoms. Why I like to point out that kind of scenario? These are all the areas which affect your liver functions. So you need to do the basic blood checkup. And you are getting huge tummy in your huge ascitic, huge fluid load in your tummy. So this is what the basic ultrasound, you are going to see the distorted liver and the CT scan. See, this is the fibrotic changes, the nodular lesion. And in case if the patient is going to take on with liver cirrhosis, you can able to identify. The second thing is you need to do your basic ultrasound to identify this kind of lesions. If you cannot identify anything in ultrasound, next stage will be a CT. your prominent findings to identify, and so many other things. That's not in the level of discussion. And you should remember these findings. You are going to see a clinical picture of liver disease, your lab picture, if it is going to be the clinically, if the patient is going down, whether the patient deserves intensive care or not going to be managed in the intensive care. All these pointers you need to see. And these are all the normal values for your basic liver function. Remember only simple thing, AST, ALT, it should be in the range of 40. And your ALP should be in the range of less than 110. And your GGT should be less than 40. So all these three should be 40. ALP, it should be around 110. Bilirubin should not go more than 2, usually 1 normal. Okay. So if it is going to be more than 1, that's a significant pointer. These are all the things you should be very cautious. And bilirubin, there are two separate things. One is direct and indirect. Indirect bilirubin is a focus for your liver-related hemolysis. Your direct bilirubin is a focus for your liver-related obstruction and your hepatocellular damage. As I told you, there are in jaundice, there are three etiology. One is pre-hepatic, intrahepatic, post-sinusoidal. So hemolytic, intrahepatic, as well as your obstructive. So obstructive jaundice, the picture will be entirely different. Hemolysis will be predominantly unconjugated jaundice, which means unconjugated bilirubin. In hepatic, predominantly direct bilirubin. In obstructive jaundice, predominantly direct bilirubin. So if you're going to see a lab report, so unconjugated jaundice is going to be, you should remember one common syndrome. I don't think in first year MBBS you might be coming across. That's nothing but your Gilbert syndrome. So you might be seeing a report with 2.1 bilirubin. Don't immediately get worried. Okay. So just see what is the component which is elevated. Based upon that, you can able to recognize the presentation. Number 1. So the basic liver function test, your CBC, your complete blood counts, and your prothrombin time, your INR. Always the liver problem will go together with kidney problems. So you need to see the creatinine. You need to calculate the glomerular filtration rate. So once a kidney problem is also there, it's called as hepatorenal syndrome. This hepatorenal syndrome will be a chronic complication. In the end-stage liver disease, usually this kind of problems will develop. That is a strong indicator for the patient to go for early liver transplant. Sometimes the patient may need to go for a combined kidney liver transplant. So these are all the things you need to be very cautious in recognizing the presentation. And next level will be your CT as well as your ultrasound. And one important thing is your ascitic fluid. As I told you, once you see the ascites, it's not only because of the liver, it is because of thousands of etiology, huge list of causes. Even tuberculosis, common TB, which is happening in the tummy, the young girl will be having ascites few days before I have seen. So it's not because of liver. So massive tummy doesn't mean it's because of liver. So you need to see that properly. That ascites is because of tuberculosis. It's a tubercular peritonitis. So you need to calculate the SAG. What is SAG? Serum acetic albumin gradient. Simply to calculate means, in case if your albumin gradient, if it is going to be more than 1.1, which means the SAG level is high, which means the cause is predominantly because of your liver, which means 95% will be because of portal hypertension. So you need to calculate the SAG. So how to calculate? Take a fluid from the tummy. Ascitic fluid, you send for blood investigation. See what is the level of fluid value. And sample of your blood count, your liver function, see the albumin levels. And deduce that from your 3.5 of serum albumin to your ascitic fluid albumin. If there's values, if it is going to be more than 1.1, there is high possibility for you to tackle a patient with liver disease. If it is less than 1.1, then there are so many other things which is based upon high protein or low protein, and very classical things. Low protein, low SAG means your kidney problems, nephrotic syndromes. So that's a different entity. So why I would like to point out, so you need to gradient, either it is a high SAG, low protein. Why low protein? The liver coagulation, protein metabolism, everything is going to go down. So the protein which is going to get leak. So high SAG, low protein ascites is nothing but your cirrhotic causes. So proteins means, if you know, remember the criteria, the Runyan's criteria. If you come into your final MBBS, you'll read all those things. So just telling you, if the protein level in acidic fluid, if it is less than 2.5, remember only these 2 points. If the protein level in acidic fluid, if it is going to less than 2.5, and if the serum acetic albumin gradient, if it is going to be more than 1.1, this is cirrhosis. Okay, classical number. Then as I discussed, these are all the lab tests you need to do. And you need to calculate your CTP scoring, which means your child pure criteria. I don't think it's in your level of presentation. So there are 5 pointers: bilirubin, albumin, your prothrombin, your encephalopathy, ascites. If the patient is going to be stage C, 10 to 15 points, if the patient is going to secure, which means the chances for survival for the patient is very, very low. Immediately consider the patient for transplant number. And then this is what is called as MELD scoring, because every human being like you and me, everybody will be in child day cirrhosis, because so everybody will be fitting into bilirubin, albumin, prothrombin, AB will be in the 0.1. So you may score 5 to 6 points, everybody. So that is not a classical picture. So that is why we came across a scoring system, what is called as model for end-stage liver disease. It's also called as MELD scoring. And the same thing which is happening for the children is also called as pediatric scoring system. It's also called as PELD, P-E-L-D. See, this is, you should remember the basic points based upon your bilirubin, your INR and creatinine. You need to calculate this. And there are so many pointers that's out of discussion. Simply about the management. Management, why the patient? First, we need to treat the cause. Whether the patient is alcoholic, stop alcohol. Whether the patient is having infection, treat the infection. Whether the patient is having hepatitis B or C, treat the hepatitis B and C first. And look for the complication. What are the complications? He may have encephalopathy, so treat the encephalopathy. He may have blood vomit, hematemesis, so treat the blood vomit. He may have ascites, so remove the fluid from the tummy, treat the ascites. And he may develop an infection which is happening in the tummy. What is called as SBP? It's nothing but a spontaneous bacterial peritonitis. Because of that, you may have fever, tachycardia, heart rate will be pounding, severe abdominal pain, persistent vomiting. So you need to do a acidic tap analysis. You need to see whether the total count, if it is going to be high in the area. So there are so many classifications for your spontaneous bacterial peritonitis. That's out of discussion. And once you identify that, it's a very important pointer, because SBP, once a patient develops, the patient will have rapid worsening of liver function. So the patient may succumb early. So you need to consider that kind of patient. For early transplant, you need to hit the patient with high level of antibiotic support. That is what I would like to insist. And hepatic encephalopathy, the ammonia is going to be very high in the level of brain. He may go for level of coma. He cannot open the high stage 3 coma. So what will you do? You need to give enema to the patient. So you need to give lactulose. Once you give lactulose, what is going to happen? It will bind to the ammonia. So the ammonia is going to get eliminated in your motion. So that's why they are putting enema to the patient who is having high level of encephalopathy. So these are all the pointers. And very important, you need to treat the ascites. Ascites, he may have massive tummy, he couldn't able to walk, he couldn't able to run, he couldn't able to climb the stairs. Someone has to lift him up. You are seeing so many patients like that now. With the end-stage liver disease, the death because of liver problem is horrible, because no one will support you, no one will help you, and finally you are going to die. So, I mean, the patient who is going to take on that. So why I would like to point out this thing, always stop the alcohol, screen the liver properly, because there are certain death in India will always be very miserable. And one certain death is mainly because of the liver related problem. You need to be very, very cautious in recognizing the presentation early. So once a patient is going to develop a massive tummy, what is going to get happen? So you need to remove the fluid. If you remove too much of fluid, what is going to happen? All the proteins is going to come down. So you should not remove more than 5 liters. You are seeing in the hospital ward, ICU, they are putting acidic tap, they will remove large amount of fluid. Now. So you should not go beyond 5 liters. If you're going to remove 5 liters, means you need to give albumin to the patient to compensate the circulatory loss. So this is one of the treatment protocol. And consistently, you need to bring down the weight of the patient because of tummy. So what are you going to do? You need to put him on, you need to give him diuretics. So diuretics means so you need to start him on 2 molecules. What is called as spironolactone, your potassium sparing diuretic. You will read in medicine, okay? And your loop diuretic, what is called as furosemide. The first line of molecule will be your spironolactone. Before considering this diuretic, the first and foremost important step I will tell you, always tell the patient if he is having this kind of ascites and other problem, tell him to stop salt intake. Tell him not to take more than 4 to 5 grams of salt in a day. That is number one, to prevent diuretic induced complications and because of your anti-diuretic hormone and other abnormalities to take on briefly. Number two, tell him to first is salt restriction. Water restriction. See, if the patient has a massive tummy, kidney will get affected. So at that point, you should not give too much of fluid to the patient. So fluid should be less than 1 to 1.5 liters in a day. That's number two. Number three, put him on diuresis, which means your molecules like your furosemide, spironolactone. See whether the patient is responding to that. How will you see? Daily, you need to see the weight. It should be coming down by 0.5 to 1 kg every day, which means there is some sort of sustained improvement which is happening. Number four, treat the complication. Blood vomit means do a endoscopy. I will show you how you tackle. This is called as blood vomit. This is all nothing but varix. Okay. So what are you going to do? You need to give blood transfusion. You need to put an endoscopy, go for banding therapy, sclerotherapy. If you are in a primary health center, so for example, the remote areas, for example, beyond Pondi, there may be a primary health centers. So what will happen? So they will not have endoscopic banding therapy and all. So what they're supposed to do, they need to put a tube. First, we need to place a Rayleigh tube to decompress the stomach. So what do you mean by Rayleigh tube? We know well about that. So you need to put a tube through the nasal into your gastric cavity. So that's nothing but Rayleigh tube. You need to put and decompress. If Rayleigh tube is not available, if the massive blood vomiting, if it is going to happen, you can think about Seng's chicken Blackmore tube. It's called balloon tamponade. And there is so many other tubes are there. That's beyond the level of discussion, etc. and other things are there. You remember SB tube, Seng's chicken Blackmore, in which if you're going to put that tube, I will show you the picture. This is what is called as balloon tamponade. With this, we can able to stop the bleed. So there are two balloons you need to go into inflate and you need to give the pressure and you are going to prevent the bleed. That is only a temporary measure before switching him into a high volume center or tertiary care center. So temporarily, you can put him on balloon tamponade in a primary health center level. And once the patient reaches the level of gastroenterology domain, so the patient has to be in either banding therapy, sclerotherapy, ICU follow-up. So hepatic coma, as I discussed, you need to put the patient on antibiotic, lactulose, you need to give oral lactulose through the Rayleigh tube and all those things. And surgery, so many huge modalities. You need to go for shunt procedures. You need to go for this tamponades as what I discussed, sclerotherapy, renal shunt is there. And there are so many etiological factors, I mean, surgical management are there. But the final line will be your liver transplant. You should remember something in liver transplant. The cost of liver transplant will be approximately 40 to 50 lakhs in India. There are two types of liver transplant. One is cadaveric, another one is living donor. Living donor means some of your close blood relatives, your close blood relatives, they're supposed to give you. Is it possible? So definitely now it's well possible because tell them we are not going to remove the complete liver. We are going to remove only a small segment in the liver. So what is going to happen? The liver will regenerate. As you are going to remember that the regenerative capacity of the liver is too good. Within a span of 8 to 12 weeks, the liver will start regrowing to the person who donated the liver to the deceased individual. And apart from that, so that is what is called living donor liver transplant. The cost will be approximately 25 to 30. Cadaveric, which means the brain dead. For example, if a person dies by not dying, if the patient met with a road traffic accident and almost every system has gone, he has gone into brain dead state, which means there are so many criteria to identify the brain dead. That's not the intention for me now. So once you've been recognized the brain dead, so you need to preserve the vital organs. So you'll be removing that and then we need to give to the disease. In India, there is no source for that because huge list of waiting lists. You need to wait for 6 months, 1 year. By the time if the patient is having severe ascites, jaundice, bleeding, means he will die. Obviously, he will die. So there is a huge waiting period in huge number of hospitals because India is rampant in your alcohol. So very difficult. So money, wealth, influence, everything to be augmented. That's very, very difficult scenario, even for the best of centers in India. These things you need to remember. So before concluding, identifying the factors, recognizing the presentation, tackling the complications, and to whether the patient to be admitted or whether the patient to be treated on OP basis, or whether the patient deserve intensive care. How are you going to recognize what is the etiological factor, whether it is because of fatty liver disease, or whether the patient is having alcoholic liver disease, or whether the patient is having any other metabolic liver disease like Wilson's. What is the reason for liver disease, and whether the reason make the patient to go for liver failure, whether the liver failure will the patient survive or not. If the patient not going to survive for a duration of time, consider the patient for early liver transplant. So this is how you need to recognize the area of such a beautiful area of liver. And with this, I'm happy to rest my presentation. Thanking you all for patient listening.
Thank you. Thank you, Dr. Arun.
Thank
Yeah,
you, sir.
we-
Thank you very much.
Thank you. Thank you. Because just now the medicine professor was here and he was commenting this lecture is more than the postgraduate level. Our students won't understand any point from this. Do you accept that?
I can able to understand, sir, but the problem is the scenario what you have been taken is the chronic liver disease means certain points we need to be very basic and certain points I don't want to be in the higher level.
Yeah.
That's why I try to convince them, at least if you recognize a patient with yellowishness in eyes, more massive tummy, and in case if the patient is having other complications like breathing difficulty, you need to recognize the patient in an intensive care and provided the patient to be managed successfully.
Yeah.
This is what the basic things we can convey in this area, sir. Yes.
Yeah, I accept that one. As
Yes.
as students, right? He was telling, right? Our students are. I remember, right, when I was taking the liver, the lecture also. I just mentioned about so many points here. You understood. He has talked about not only anatomy, even the biochemistry aspect also, right? So this is our students are really brilliant students, intelligent students.
Sure. Happy for that.
Yeah. So, see, even the resource person within 1 hour, he has judged you, right? So now I want questions from this side. At least one question from each table, that way. Yes, table 1. Any questions? Interaction? Yes, Adav. Adav is there? Adav? Yes, yes. No questions. Right. Table 2. Some interaction, we want some interaction. Everything is recorded so that in future, right, we will come to know, right, what's in arranging the guest lecture, whether it's useful. Yes, yeah, you want to.
Hello, sir. Can you please explain the basis of liver biopsy and why is it done?
It's a fantastic question, but I forgot to mention about that. Really happy for you to take on with this question. See, liver biopsy in liver disease is not a major investigation. See, because most of the time, there is no need to identify a scar in your hand. Okay, so most of the time, the diagnosis will be very, very obvious. If the patient is alcoholic, the possibility mainly because of alcohol. The other problems will be very, very less. So you cannot work in for everything. If you're planning for a liver transplant, you need to do the complete cascade of workup. I will tell you some things. For example, a young female, just 25 to 30 years old, who is having deep jaundice, bilirubin, for example, in the range of 15. And the patient is coming to you, is not an alcohol, usually females, but nowadays females are also taking alcohol, it's a different issue. But usually we may consider that she is not an alcoholic. She is not morbidly obese. She is not having any other problem. She is not taking any homeopathy, native medications, or any over-the-counter medications. And she is not having any evidence of fever. She is not having any evidence of outsourced water poisoning and other stuff. So usually infective factors like hepatitis A, E, everything is negative for the patient. So you cannot able to identify any problem or etiology. So your ultrasound doesn't seem sure and your liver function with your medicines keeps on worsening, not improving at all. So what is the reason? Whether you are suffering from autoimmune liver disease or any other metabolic parameters, you couldn't able to diagnose. So that's the area you need to consider the patient for liver biopsy. For liver biopsy to get happen, you need to be cautious. The patient's coagulopathy, platelet count, clinical picture, all those things you need to take into account before considering the patient on liver biopsy. Nowadays, a gun technique which is available through ultrasound guide, we can directly go with that.
Thank you, Dr. Arun. Yeah, Hamdan, any questions? Table 5, table 6, table 7, table 8? Yes, table 8.
Sir, during liver transplant, whether they take any particular segment and place it in the.
No, for example, if you want to consider the liver transplant, to whom you are going to consider based upon the liver size and from whom you are going to remove the liver. So that is what the predominant thing we need to assess. And for example, if you're going for a split liver means which is you are going to splitting up the liver for various patients. And you can use that for 2 patients. If you're going to take a predominant of left lobe or right lobe, so split liver transplant, if you're going to consider, that's a separate entity for you to address that area. And usually that's not based upon that segment, is based upon the lobar anatomy. So which will be approximately around 30% to 40% of the liver fragment, which is going to extract from the donor.
Thank you, sir.
Thank you.
Table 9. Vaishnavi? No question. Yes. Yeah, here somebody wants to ask some questions. Yes, boy. Nothing. Sriram? No question. Lavanya? No questions. Yeah. From this. Yeah. Yes.
Sir, after hepatic failure, is there any way to bring the patient back to normal conditions, or is it complete like end stage?
No,
condition?
not like that. Suppose in case if you're going to land up with any evidence of acute hepatic failure, for example, if the patient consumes too much of paracetamol and the patient is going to land up with evidence of hepatic failure, most of the time we can able to bring down the clinical scenario rapidly. But there are certain criteria to recognize that also. That's called as King's criteria. So if the INR or prothrombin time, even after treatment, if it is consistently worsening, the bilirubin is not improving at all, if the patient keeps on worsening, brain function is not at all improving, even after that, which means the initial protocols, whatever you have been trying to the patient, starting from the head to foot, nothing works. Then that point that the patient to be considered for liver transplant. And nowadays, so many other things as a bridge to liver transplant is available. What is called as plasma exchange, your plasmapheresis. With your plasma exchange, which means you are going to remove your unwanted substances which is being happening and you are going to circulate with the normal one. So what is going to happen? The liver detoxification is going to get well augmented. So at that point of time, the liver transplant may prolong, you can prolong the liver transplant to that kind of patients. But once a patient is going for evidence of hepatic failure, the liver synthetic function completely gone, and all those factors which has been mentioned in the criteria is going to get taken on. At that point, usually without liver transplant, the chances of survival will be less.
Okay, sir. Thank you, sir.
Thank you.
Yeah. What about Satya Sai? Any questions from Satya Sai? Anybody there? There. Yes. Madam Saujanya? Dr. Muniappan is there? You remember Dr. Arun, Dr. Muniappan?
Muniappan sir and Professor Arunmuli sir, both of them are my very favorite professors. Thank you, sir. I mean, I came to know that you are also being here this crowd.
Yeah,
Thank
he is
you.
in Satya Sai. Dr. Muniappan is in Satya Sai.
Sure, sir. Sure, sir.
Okay, any other questions? Questions from Satya Sai? Okay, Dr. Arun, finally,
Yes,
to,
sir.
yeah. So you people, the endocrinologists and hepatologists, according to you, the most important, the etiology for liver cirrhosis is alcohol abuse,
Yes, sir.
right? You have
Yes.
mentioned 70 to 80% is alcohol abuse.
Yes, sir.
Right, then what the government is doing and what you people are doing to eradicate this liver cirrhosis from the community?
If you want me to give the right proper answer for this question as a gastroenterology point of view, we are here to counsel the patient once the patient on day being seen on day one itself, sir. But how many patients are turning up to a OP? That is very, very important. See, once a patient is landing with multiple complications, the patient is turning up to the gastroenterology. Prior to that, most of the time physicians will be managing. So early recognition of fatty liver is one of the most common thing we need to counsel. So fatty liver means it's always a death knell to be very conscious. The patient need to be in regular follow-up for that. And what are the steps we are taking as of now, and what is the step government being taken as of now? Regarding government point of view, I'm not very sure about that, and I'm not aware about that. I don't think any steps being taken on. Regarding the doctors, from our point of view, the treatment protocol has been so enormously well developed, and along with the liver transplantation program, it's been so rampant nowadays in India because of the living donor transplant being well established. So recognizing the patient in an earlier way is the most important thing that we can address, and counseling, and very importantly, post-transplant. Most of the time, the patient will go for alcohol abuse again, recidivism. So at that point of time, we need to be very, very cautious in counseling. Psychological support is very, very important. That is what we can give, even with huge list of molecules being available in the field of gastroenterology to tackle this kind of presentation. The more and more psychological trauma has to be strongly addressed to this kind of patient, then we can able to stop this scenario completely well, sir. And family support, behavior, cognition, encouraging, and make the patient very active. If the patient is alcohol, never discourage, tell him to stop, and always keep the patient very active, and focus on your goals, aspiring events and jobs extensively well. That would captivate this kind of major worsening psychological events because of alcoholism, which is going to take on. That's the area for a doctor to get addressed. Not only on prescribing the medication, not only the investigations, psychological trauma to be strongly addressed. That is what I would like to do, and I'm enforcing on that also, sir.
Okay, thank you, Dr. Arun. But I don't think the government, right, they are very particular about this, and then they open all the shops, right?
Yes, sir. What you said is absolutely true.
Yeah,
Then we only need to take on with that question, sir.
Yeah, you know, in Pondicherry.
Yes,
Yes.
is very commonly available.
Yes,
along-
yes, that's what. So the government is not worried about that one, and maybe this is one of the measures of population control.
As of now, they have been considering like that, sir, because the huge amount of money being poured and more than 50 to 60% of the income being generated in that area. So that is why the main reason no one is willing to stop it out.
Yeah, that is true. And finally, right, when we were students, right, my seniors, they used to tell, right, in India, what's the problem with alcohol is our people, they take alcohol and they don't eat the protein diet. That is the reason they get the cirrhosis. Is it true? Because even now, some of the students will be having that misconception.
Sure, sir. See, alcoholism based upon how much of alcohol. That is number one. Number two, based upon the starvation. If you're not going to take your food in the right time, because food, once it's going to get mixed with alcohol, definitely the metabolism will be more prolonged and rapidly. And toxicity levels will be more less when you're going to take along with your food. But starvation and without only alcohol, that definitely will be having rapid worsening of symptoms. And one more thing I would like to point out, even I have given some lecture regarding female alcoholism. Females rapidly worsen. So always we need to be very cautious. I have seen nowadays I'm coming across multiple female alcoholism too, and I have seen many patients with female cirrhosis. So succumb because of the liver events, because of the estrogen pathway, metabolism pathway, COAP pathway. There are multiple things are there being related to females. So the females, even with minimal dose, will be having the serogenic dose of alcohol. There will be rapidly worsening of events because of alcohol. So all those pointers to be well addressed, and females definitely no. And nowadays, pregnant women, they are taking alcohol. I have seen some patients because of that also, with that also. So all these things, you should counsel them, stop, educate them more, and reaching the public to the root level. That's the main area we can able to stop it also.
Yeah, thank you for your final, the message, no alcohol, right? That too particularly the girls. Okay, yes. Any other
Well, that's
questions?
it.
Okay, thank you, Dr. Arun. So we have come to the fag end of our program.
Sure, sir.
And then the organization secretary will continue.
Thank you, Dr. Thank you, Dr. Arun sir, for your insightful and enriched guest lecture. Your experience and knowledge in clinical liver disease has enlightened the students and left a long-lasting impact on us. Thank you, students, for your Q&A session. Now I request our organizing chairperson, Professor Arulmoli sir, to felicitate the guest speaker, Dr. N. Arun sir, with an e-certificate.
Dr. Arun, if you are here, we used to put the shawl and then the memento also.
Sure,
Since
sir.
it's, since it's
Thank you.
online, right?
Yes.
That's the e-certificate. Can you see?
Yes, sir, I can able to see it
Yeah,
well.
yeah. So that e-certificate I will send to you.
Sure, sir.
And
Thank you.
also all the proceedings was recorded. I will send the recorded version also to you.
Sure, sir. Thank you very much.
Okay.
Thank you, sir.
On behalf of SSMCRI, also we thank you, sir, for enlightening our students on chronic liver disease. Thank you so much, sir, Dr. Arun, sir.
Thank you very much, ma, and thanking all the students. I don't think the session was completely boring. To some extent, you can able to enjoy with the minimal knowledge sharing what we have been done. Thank you very much for all your kind cooperation. And thank you, team organizing, who gave me a wonderful opportunity to meet you all and to go ahead with my past memories, what's happened. Thank you very much.
Thank you, Dr. Arun. Yeah, vote of
Yeah.
thanks. Finish, huh? Thank you, thank you.
Thank you.
Finish. Thank you.